Good morning, everyone. I'm Dr. Hong Song. I'm one of the nuclear medicine physician radiologist in the department at Stanford. So today I'm going to give you a quick overview of advances in prostate cancer imaging. And this is mainly going to be focused on PET, and I'm going to touch upon some of the new advances and theranostics in terms of treatment as well. So you're probably, many of you are probably familiar with this a chart that sort of describing the natural history of prostate cancer. You have disease initial diagnosis, then patients get treatment, definitive treatment with prostatectomy or radiation, and then for most of patients, a lot of patients, they're cured. But for some patients, they will experience biochemical recurrence, and some of this patient will have disease and that they'll be detected, then can be treated again with multiple radiation treatment, hormonal therapy, etc. A lot of this patient will experience remission, and a lot of them will have multiple events of biochemical recurrence and remission. It can last for decade, actually. But eventually, some of these patients will develop what we call hormonal resistant or castration-resistant prostate cancer. Unfortunately, at that stage, disease can become metastatic. It becomes quite difficult to control. We do have second-line treatment, chemotherapy, some second-generation hormonal therapy, but at that time, disease tend to grow a little bit out of control. But we do have some other treatment, some like recent, you probably heard of Pluvicto, Xofigo, that for late-stage disease. But what I want to emphasize today is throughout the whole disease, prostate cancer disease progress, imaging, especially PET imaging, has started to play a more and more important role, if not an indispensable role, including MR, PET-MR at initial diagnosis to guide biopsy for staging, to guide treatment, and also especially at biochemical recurrence, PET, PSMA PET, to tell us where the disease really is for, say, radiation oncologists to target it. And also, more recently, imaging play important role for patient selection for this radioligand therapy, Pluvicto, or for treatment, evaluating treatment response. So this all become an integral part, imaging has really become an integral part of patient management in prostate cancer. So this is sort of a little bit history that there are multiple PET imaging agents we've done sort of in the past, say, 2 decades. Initially, we have FDG PET, which only really imaging well for a small fraction of prostate cancer patients when the disease had become really aggressive. Then we have sodium fluoride PET, which only really image bone metastasis. Then in 2012, 2016, we have choline PET and fluorosaccharin PET. Maybe you had it done before, but this has improved imaging. But more recently, we have PSMA PET. In 2020 or 2021, 2 PSMA PET agents with PSMA 11 gallium-68 PET. The other is DCF-PYL fluorine PET that truly, for lack of a better word, revolutionized prostate cancer imaging and help. Yes, go ahead.
Tell me what PET imaging is. What does PET stand for?
Right. So PET stands for positron emission tomography, meaning that, for example, the PYL PET, fluorine, it's a radioactive radioisotope that emits this radiation called a positron. Essentially, it is a positive electron. So when it emits, it will annihilate with normal electron. Basically, positron is the antimatter. So it annihilates with normal electron that emits this pair of 511 keV photon that can be picked up by our PET machine. So if we take that to a PSA molecule that targets to the prostate cancer, then we're able to see it very clearly. All right, yeah. You heard a lot about PSMA. What is it? It is a prostate-specific membrane antigen. It is highly expressed on prostate cancer. It is also associated with aggressiveness of prostate cancer. So the more aggressive the cancer becomes, there's more PSMA expressed. However, it does express on some other normal tissues, which has implications. But for prostate cancer purpose, it serves a really good marker for prostate cancer tissue so that we can target it and pick it up. So this is a normal PSMA PET sort of imaging. You can see that most of the dark, you can see the dark part is where the radio tracer is. This is normal patient. There's no disease, but you can see the tracer is excreted through kidney, go to the bladder, and then some of it is excreted through liver and spleen and bowel. But there's also normal PSMA expression on salivary gland and the lacrimal gland. There will be implication for this for therapy. I'll touch upon this later, but this is sort of the PET imaging you see with a PSMA PET. So there are 2 phase 3 trials that are being done for PSMA PET, especially for DCF-PYL PET. The first one is a kind of CONDOR trial. That's being done at the setting of biochemical recurrence, meaning patient had initial treatment, their PSA goes to sort of undetectable level, but then PSA start to rise, and we don't know where disease is. Then they did this PET to pick up where disease is and compared to conventional imaging, and shows much better detection rate. And you can see the detection rate is actually increases with increasing PSA. When the PSA at that stage reaches over 5, the detection rate is almost 97%. You will almost guaranteed to find something on the scan. Another trial called Osprey trial, the phase 3 randomized multicenter trial, is also looking at biochemical recurrence and also staging. I'll touch about this later. But for biochemical recurrence, it found a similar data that as PSMA PET has really good detection rate, close to, as the other CONDOR trial, close to almost 100% with increasing PSA over 2. So with this 2 large phase 3 trial, FDA approved PSMA PET in late 2020 and early 2021. And since then, there are multiple PSMA PET agents on the market FDA has approved. The most recently, you can see May of this year, FDA approved this newest PSMA PET agent. Yes, go ahead.
It's great to see the results.
That's a great question. So specificity is also, it's not 100%. For example, it does pick up by other tumors, but the level of uptake usually correlates with higher specificity, meaning if there are high uptake, if the pickup you can see is really intense, then we have more confidence to say it is prostate cancer. So add some of the scan for as staging, because we can do surgery, we take out the lymph nodes, we can do histopathology correlation. The specificity of PSMA scan is over 90%, actually. So it's actually pretty good, but it's not 100%. It does get picked up by some other tumors or some other process, but at lower level. Yeah. So since PSMA PET has been approved in the past 2 or 3 years, it has quickly been adopted by multiple professional societies into their guidelines. For example, our Society of Nuclear Medicine Procedure Guideline has said that PSMA PET is indicated for all this routine clinical use for prostate cancer, including initial staging, including biochemical recurrence situation where I talked to you about, and including when patients develop castration-resistant prostate cancer can be used for restaging, and for patients who are being evaluated for radioligand therapy for Pluvicto. This can be used for restaging for patient selection. The potential other clinical uses are also being evaluated currently. So the NCCN guideline, which a lot of oncologists use, also have incorporated the PSMA PET into their practice guideline, and including all these similar indications. But you see the wording in the guideline is actually quite, I would say, impressive. It says the panel does not feel that conventional imaging is a necessary prerequisite to PSMA PET, and that PSMA PET CT or PET MR can serve as an equally effective, if not more effective, frontline imaging tool for this patient. Meaning, for a lot of patients, for a lot of this indication, you can go directly to PSMA PET CT or PET MR rather than go through other conventional imaging. PSMA PET has been shown is equal or superior to some of the conventional imaging. However, the guideline also states that PET CT or PET MR results may change treatment, but may not change oncological outcome. So this is key. This is very important, meaning that for now, we have this for 3 years. For now, we know for sure PSMA PET can pick up more disease. It sees better. But what does that mean? Say, at staging biochemical recurrence, we pick up small disease. It's usually low burden disease that conventional imaging couldn't pick up. Does that change? Does that mean we can improve patient overall survival down the road? We don't know that yet. In other words, what do we do with this newfound powerful tool? Like, for example, patient with low burden disease, do we intensify treatment? How do we do it? These are all unanswered clinical questions that need to be addressed. But there are sort of retrospective analysis of some of the data. We looked at it. There are suggestions of it, but it is not proof. There's certainly we need large-scale prospective trial, which some of them have been done to prove that. Some of the study we done here, we also looked at PSMA PET at biochemical recurrence, also reach very similar conclusion that when PSA is over, say, 1, the detection rate is close to over 90%, close to 100%. We also looked at metastasis-directed therapy, meaning for patient at a biochemical recurrence, if PSMA PET detect disease, some of our radiation oncologists here will treat them with radiation, targeted radiation. For example, you can see on the left side, this is a PSMA PET patient on image A. You can see there are the small dot, black dot at base of the left neck. Those are metastatic lymph nodes at we call supraclavicular stations. So those are the only disease at biochemical recurrence. You can see the PSA is only 0.98, but we'll pick up all these tiny lymph nodes. So our radiation oncologist will be able to see that and target with radiation. Then you can see 32 months after this radiation therapy, we repeat PSMA PET, there's no disease there. Okay, so we can see better and we can direct treatment for this newfound tiny little tumors. We can pick up disease much earlier. So we looked at this and say how this help. Like, this is retrospective data again. So we can see that with MDT, the median time to recurrence is improved, to the next recurrence improved to 32 months, which is sort of consistent with a lot of the retrospective studies in the literature, but there's certainly, we're still waiting for some of the larger prospective study to sort of prove that. Other study we're trying to look at, we use AI-based lesion analysis of PSMA PET at biochemical recurrence. We use this AI to work with a company called Exenia Diagnostic, using this tool AI to call it Polarify. So the computer able to not only see the lesion, but analyze based on how big the lesion is and how intense the lesion is, where it is, and assign score in terms of whether it's in the tumor, it's in the lymph node, and it's bone, where is it the bone? So we can sort of use this score to correlate with outcome. So we try to look at how that gonna affect associated with the outcome. And we can see that for patients with MI PSMA score, which is MIMB, meaning bone metastasis. For patients with bone metastasis at biochemical recurrence, if they have higher burden of bone metastasis, they tend to do worse at meaning the next biochemical recurrence will happen earlier. This is not surprising. I mean, intuitively, it kind of makes sense, but there are implications for this analysis because remember, this patient are treated with metastasis-directed therapy. So are we, because of this improvement in lower tumor burden, because we treat them, or because we undertreat the patient who has higher tumor burden? So this is an open question. This is sort of suggestive we need to look into this situation more closely. But if you look at SUV max, meaning how intense of the uptake alone, it does not gonna make a difference in terms of how high or how low the uptake is in terms of the next biochemical progression-free survival. So I want to mention at Stanford for all these studies, trials in the past several years, we've done PSMA PET before FDA approval for gallium-68 fluorine-18 PSMA PET. We've done over 400, 500 patients at no cost to patient, just as part of the participation of our research studies. So change a little about another tracer called the GRPR. It's also heavily investigated at Stanford. This is gastrin-releasing peptide receptor. This is also another PET agent that we can use to target prostate cancer. This is also expressed on prostate cancer, although the biology of it is still a little bit 100% clear. Some of studies show that it's relatively had high-level expression on relatively low-grade prostate cancer, but some other studies have shown that expression of GRPR tend to be associated with a patient that will progress. But nevertheless, we also evaluated PET imaging using this agent. You can see the distribution of this agent is very different from PSMA. There's no salivary gland uptake. It's still excretes through kidney. There's some pancreas uptake, but it's very different distribution. This has implications for a therapeutic application, but I'll touch upon later. So we also look at this agent compared to PSA at biochemical recurrence stage. And you can see that this agent can pick up prostate cancer about in 72% of the patients, slightly lower than PSA, a PSMA PET. So we compare these two PET agents in the same patient population. We did a study. So you can see that on the right side column, the column chart, on the right side column, the PSMA PET, it pick up more disease. On the left side is the GRPR PET, it pick up less disease. That we know. However, you can see there's a little red on top of the GRPR. So there are about 10% of the prostate cancer patients are actually PSMA negative. So if they are PSMA negative, we cannot pick up with PSMA PET. So GRPR PET can help with that. Okay, so this is something new. We are looking into. This community are very interested looking to that GRPR PET can be complementary to PSMA PET to pick up more lesions at this stage. So one of the trials we're opening for now at Stanford is we're looking at this copper-64 is also another PET agent labeled Bompson, which is targeting GRPR to look at biochemical to pick up lesions in patients who are PSMA negative. And this is an imaging study. We try to demonstrate that for this patient population, Bompson PET can pick up more lesions. So that's biochemical recurrence. So a little bit about cancer staging. PSMA PET also played a very important role. This is data from a large cancer database for close to thousands of patients to look at upper staging of prostate cancer staging by PSMA PET. With increased adoption of PSMA PET, you can see that upper staging is close to 18% by 2017. This is before the FDA approval. Okay, thank you. But that also makes a huge difference in terms of about 1 in 5 or 1 in 6 patients will have upper staging of prostate cancer at initial staging. So at Stanford, we also looked at GRPR and PSMA PET at the staging to guide, say, biopsy to for local treatment, to guide local treatment in combination with MR with high intensity focused ultrasound or with high dose rate brachytherapy. You will hear about that later. Now we'll switch gear a little bit, talk about Theranos, the radioligand therapy. So what that is, so basically PSMA PET, you use PSMA, a small molecule tagged with a PET agent, a fluorine-18 gallium-68 to see the disease. Now, if you switch out that PET radioisotope with a therapeutical isotope, there are a lot of, for example, lutetium-177, it's a beta emitter. It can deliver radiation to prostate cancer. Now it's not an image agent. It becomes a targeted therapy agent. Okay, so there's a lot of research in that aspect. So one thing you probably heard of is called Pluvicto. This is the PSMA targeted lutetium-177. It's a therapy agent. This is a phase 3 VISION trial that's completed in 2021, and that show that Pluvicto improved both biochemical progression-free survival and overall survival. And FDA approved this in March of 2022 last year. And at Stanford, we're part of this trial, and we started clinical treatment with patients with Pluvicto since June of last year. And we've already treated over about close to 100 patients so far. And you can see PSMA PET play an important role for selecting patients who are eligible for Pluvicto treatment. For example, this patient, you can see, on the left is before the treatment. A patient has widespread metastatic disease and pretty intense uptake on PSMA PET. If the uptake is intense, usually our guideline is over liver, then it will be able to deliver enough radiation dose to these lesions, so they are eligible for Pluvicto treatment. So we can also use the PSMA PET to evaluate treatment response. You can see some of the lesions after 3 cycle treatment, some of the lesions have less uptake, so the PSA drop. So over close to 50 to 60% patient will have PSA drop. This is a late-stage prostate cancer patient who are refractory to hormonal therapy and also chemotherapy. This is really sort of the last, almost the last resort treatment for this patient. So we also part of some of clinical trials, and the PSMA-4 trial, Stanford part of. This is to evaluate a patient who a little bit early in the disease progress, they are chemotherapy naive, but hormonal resistant. We're also another trial, PSM addition, still on just finished recruiting patient that looking at earlier in the disease progress for Pluvicto to treat patients who had metastatic hormonal-sensitive prostate cancer. We'll see those results probably in the next year, a couple of years, hopefully. And also, soon we'll open up trials for another PSMA therapy agent that is labeled with copper-67, similar to lutetium-177. This is a bispecific PSMA. So this molecule has 2 PSMA molecules on that. Theoretically, it binds to the tumor with better affinity and stay longer so that it can deliver high radiation dose. Also, we are part of the clinical trial. As I talked to you earlier, GRPR, another agent for prostate imaging that also can be used for treat. So we are part of this NeoRay trial that use a GRPR targeted agent labeled with lutetium-177. And phase 1 study has been done. We're waiting for phase 2 some of the phase 2 trial to open. Another trial that's going to soon open here is COMBAT trial. You can hear a lot more about this at the clinical trial breakout session. It also use copper-67 to target bombesin for this metastatic castration-resistant prostate cancer patient that refractory to chemotherapy. Another agent I want to touch upon is alpha therapy. You can see that you probably heard of it. It's very effective, more powerful radioisotope called actinium-225 compared to the initial lutetium-177. A patient, look at on the right side, can see a patient that in 2015 they did this initial study. You can see patient who progressed on lutetium-177 PSMA, then we treated with alpha, then it all mostly cleared all disease and PSA dropped. The problem is there's some problem with toxicity in terms of, you can see the salivary gland I told you about earlier, PSMA in the salivary gland, but you can see after treatment, salivary gland almost all gone. So there are a lot of patients experience dry mouth because xerostomia that cause quality of life issues. So we're looking into that, how to resolve that. So some of the future trials in plan in terms of using alpha therapies, but it's still in early planning stage. Lastly, I'm going to touch upon some of the imaging equipment we use at Stanford, which is important to acquire high quality imaging for patients. So Stanford is always at the cutting edge of the best imaging equipment. For example, this is the fully digital full body SPECT CT sensor. This is the one of the top earliest 3 scanner that's installed in the world. We have this a multi-detector SPECT CT system which can scan a patient a full body in 12 minutes. It's on par with some of the fast PET scanners. And we're using that to look into, for patients treated with Pluvicto, we're using that to evaluate treatment response earlier compared to PET CT. This is a patient we pick up some of the PSMA negative liver metastasis on the SPECT CT. We're also looking to how to quantify tumor volume in predicting an outcome, a treatment response outcome for Pluvicto treatment. These are some of the study we're doing here. Another sort of cutting edge PET CT is, we call it extended field of view PET CT. Standard CT you can see is right up corner, is about 25 centimeter ring. It's already sort of state of art, but now we have, there's a concept for a full body CT system, but that's too sort of extensive, too expensive, too construct. So now we have this extended field of view PET CT that length can be ranged from 32 centimeters to 128 centimeters. So with that, we can improve. Imagine with more detectors, we can detect more lesions with high sensitivity, decrease scanning time, and potentially decrease amount of radio tracer to be used. But more importantly, then give us ability to do scans dynamically. So we'll be able to imaging 2 tracers at the same time. That has implications for prostate cancer. For example, we know that for some patients, not only we need to scan with PSMA PET, but for some patients, we need to scan with FDG PET to help us to sort of stratify how they're going to respond to Pluvicto treatment, how their disease will progress. So this new system will help us to sort of scan potentially 2 tracers at the same time, so give us ability to sort of understand prostate cancer better in the patients. And last, I will touch upon a basic research side. Stanford is investing heavily into discovering, developing new radio tracers. This is our next generation research cyclotron that's being built in Europe, that's already shipped here. Arrived last month, that's being constructed on our research park. And we think this, we anticipate it's going to be fully operational by early next year. So we have the ability to produce more research radio tracers for developing new radio tracers for prostate cancer. So this is our view for prostate cancer imaging, how to advance prostate cancer. It's really a multidisciplinary sort of field. We have to understand the cancer genetics, biomarkers, a better understanding of tumor microenvironment and its interaction with the immune system, then work with radiochemists to develop all these new radio tracers. At the same time, we work with physicists, companies to develop modern, better imaging tracers, and more recently we have AI to help us to read this PET or extract more information from this PET for us to better understanding prostate cancer. The ultimate goal really for us is to improve prostate cancer imaging so that we can provide personalized cancer management for every single prostate cancer patient. So with that, I would like to thank my colleagues in oncology, radiation oncology, urology for their support. Of course, I want to thank all the prostate cancer patients that come to Stanford to see us, and also my colleagues at radiology and nuclear medicine. Thank you very much.
Thank you so much, Dr. Song. We do have a few questions on live stream. And then again, if anybody in the audience has questions, please be sure to write them down on the cards.
Yes.
Just for the sake of time, we're going to try to have the cards come over here so we can keep things moving along. The first question.
What is the median time to biochemical recurrence after initial treatment with surgery and with radiation?
Yeah, that's a good question. Not every patient will experience biochemical recurrence. I think will be probably around 20 to 30%. I think that in that range. That typically, if it happens, it will be somewhere around within the first 10 years.
Surgery and radiation?
Right.
They're equal?
Yeah, yeah, definitely.
Another comment was regarding PSMA PET being more for detection and not for treatment. Can you speak to that?
Right. So PSMA PET is for detection. That's true. But as I talk about the theranostics, it swap out that fluorine-18, the image radioisotope, with the therapeutic isotope like lutetium-177 or actinium alpha emitter. You can use it for treatment. Same molecule targeting PSMA used for treatment. Yeah, we've been using that. It's for clinical practice since last year.
And then another question, how safe is the nuclear medicine treatment?
Right, that's a really good question. So overall, clinically, most patients told us, and from the clinical trial and from our experience, the side effect is actually very mild compared to, say, chemotherapy and hormonal therapy. Most patients tolerate it very well. I personally treated several patients who are 90 years old, and they're doing fine. But that being said, there are certain side effects associated with the treatment. For example, for some patients, it could cause a marrow suppression, drop in, say, anemia, like drop in platelet, drop in red blood cell. That could happen. But for majority of the patient, the toxicity is mild. And some other toxicity can be like dry mouth, and long term, there could be some effect on renal function, but most of the side effects are generally mild.
Thank you. Two more. I'm on surveillance, but biopsy was just MRI. Is a new PET scan indicated for aiming future biopsy, HDR brachytherapy, or surgery?
Right. That's certainly, if in the, it is not, in the guideline, it's not approved yet, but we are actively researching that field. We think it's promising. Yeah.
And then last question, is there any correlation between SUV mean and PSMA score?
Right. So the high the SUV PSMA score is based on how high the uptake SUV relative to say blood pool or liver or parotid gland. So we use that as a reference. Yes, it has some correlation. That's right. The higher it is, the higher the PSMA score. Yeah.
Okay. And then we have one more. If a bright spot lights up in a rib, how likely is it a false positive?
That's a great question. So we do see that a lot at staging. It depends on a lot of things. Depends on first whether that's the only lesion, and depends on how it looks on the anatomic imaging. For example, on CT, what does it look like? And depends on how hot it is, like how intense the uptake is. If It's the only lesion, and uptake is mild. The chances are, and the CT is, anatomic imaging is not very conclusive. The chances of its being positive is actually very low. There's a study that being done. They looked at 66 patients with in that category. Only one lesion turned out to be true positive.
Okay, thank you so much, Dr. Song.
Thank you. Thank you all.